So we'll briefly talk about this management of diabetes in older adults. And there were new guidelines that came out in just last month. I think useful discussion. So we'll go ahead and start this. Next slide. Can we do it? Okay, so the three things I want to discuss today is geriatric syndromes associated with diabetes mellitus. So we're talking about patients who are more than 65. And the other thing is, the other important thing I feel is the obesity in older adults, which can lead to diabetes. And then just some highlights from these recent Endocrine Society guidelines that came out recently. Next slide. So, diabetes is extremely common in patients who are more than 65 years of age. About a quarter, about 25% of the individuals more than 65 in this country have diabetes. And about 90% of that, or more than 90%, is type 2. Few have type 1. If you look at nursing home population, almost half of the individuals, the patients living in the nursing home have diabetes. Almost all of them have type 2 diabetes. And the reason for increased prevalence and increased incidence of diabetes in this age group is the following. The loss of muscle mass, which is sarcopenia. Muscles are excellent source to pick up glucose, especially in the post-meal state. And as the individuals lose muscle mass, their blood sugars, especially the post-meal, blood sugars start to run high. Also, increase in adipose tissues will cause insulin resistance, and therefore the incidence of diabetes is higher. Decrease in physical activity will lead to increase in adiposity, increase in fat cells, and also loss of muscle mass, and therefore it will contribute to it as well. And like with any other cell in the body, the beta cells, as the patient's age, their secretory function goes down. So all of this lack of insulin production, increased resistance to the actions of insulin because of loss of muscle mass and increased adiposity causes increased incidence of diabetes. Next slide. And diabetes affect everything. Functional. If the individual has diabetes, then their functional status is affected, their life expectancy expected compared to their peers, and there's increased risk of institutionalization, nursing homes, and SNF placements for individuals with diabetes because of the complications associated with it. Next. Okay, so this is just a repetition of what we have talked about. So if you see, with aging and the sedentary lifestyle, it will lead to poor fitness and increased adiposity, which will cause poor quality of life that can lead to, besides diabetes, other things such as congestive heart failure, which can further lead to weight gain and poor fitness, and it becomes a vicious cycle, and eventually it can increase the risk of morbidity and mortality in individuals with type 2 diabetes. So basically, it's the lack of poor physical fitness and loss of muscle mass that is causing all of this. Next slide. So this is important because it seems like the weight gain and the loss of muscle mass is the major contributor to diabetes, increased incidence of diabetes in this age group. So this is where a modest intentional weight loss actually can help them a lot. If these individuals can cut down their calories, they can increase their physical activity by just a little bit, about 150 minutes a week of modest intensity exercise or activity, and removing some of the high calorie stuff from their diet, then they don't have to develop diabetes. And if they can do that, then that can reverse and prevent the onset of diabetes in these individuals. So this is intentional weight loss, and we're talking about eating a little better and increased physical activity in these individuals. Next slide. So this is just an example, what they can do. These individuals have arthritis and their mobility is limited. So stationary bicycle, resistance training, that's the most important thing. And again, resistance training will help the bones and will also help the muscle mass. And loss of muscle mass, again, is one of the major contributors to insulin resistance and eventually diabetes. So resistance training is what they need to do. And this is just, these pictures are just to highlight the same. Next. Diabetes can affect any age group, but especially in geriatric patients or patients who are more than 65 and older, it affects all the geriatric syndromes. So urinary incontinence, which is very common in people more than 65. If they have diabetes, it can cause neuropathy, can cause further issues with the bladder control. Pain can get worse as well. The perception of pain can be altered because of diabetes and also because of neuropathy. Depression, any chronic medical problem will increase depression. So and diabetes can do that as well. Cognitive impairment, which is a major challenge in this age group. Diabetes can also make it worse. Falls, either related to neuropathy or from hypoglycemia. Diabetes can also affect the bone health and can increase the incidence of osteoporosis. And most importantly, polypharmacy. Most individuals in this age group are already on many drugs, and if you add a couple of diabetes medications, it does not help the polypharmacy, and then there are increased interactions between diabetes medications with the other medications that they're already on, and cost is also a major problem that they will run into. Next. So, obesity, in diabetes, we talked about this. This is common because of lack of physical activity. Really, no obesity medications are indicated for these individuals because they all have side effects, and we really do not want to start any obesity medication for these patients. So what we should do is not to prescribe medications in the first place that can lead to weight gain. So we have to be very mindful of this fact that they are at risk for gaining weight. So medications that we should avoid, I'm not saying we should stop these medications if they're already on it, but we should try, not to start it in the first place. So from diabetes standpoint, we have the pioglitazone, which is the Actos, insulin, sulfonylureas, which are glimepirides, and the glycerides and other medications. If we can avoid using SSRIs if they're not indicated, or mirtazapine, which is Remeron, we should do that. Antipsychotics, it's a very common in nursing home setting. Beta blockers, and again, I want to highlight this. I'm not saying that stop the beta blockers, but if we can avoid using it, we should do that. And the steroids, intra-articular or injections, if we can avoid that, because that will lead to weight gain, loss of muscle mass, and can increase the incidence of diabetes in this age group. Next slide. So these are some of the guidelines from the Endocrine Society. So screening for diabetes in patients more than 65. The best test that Endocrine Society is recommending is fasting blood sugar or plus minus A1C. So these are the two tests that they are recommending. So fasting is about 8 hours. They should not be on any restricted diet before this, because that can affect the fasting blood sugars. They should be on their regular diet, and then they should fast and have the blood work done in the morning. And again, if it's more than 126 twice, then it's diabetes, and we can always do an A1C. But this is slightly controversial, and I don't want you to be too concerned about this. They're recommending that if the A1C or fasting is in the pre-diabetes range, meaning that the fasting blood sugar is between 100 to 126 and the A1C is between 5.7 to 6.5, then we should do a 2-hour post-meal test. But this is only indicated in very high-risk individuals like Hispanics, Asian Americans, Latinos. So if you are, and the reason for this is the A1C in this age group is not very reliable, because the lifespan of the red blood cells, which represents A1C, is not 100% accurate. So by far the best test is fasting blood sugar and A1C. But if you're concerned that the A1C value is not reliable because they're on iron pills, or they're getting erythropoietin injections, or there's some other disease that is affecting the red blood cells, then, and if you have a high risk, if the patients are high risk, then a 2-hour post-meal challenge test should be done. However, A1C and fasting blood sugars are by far the most common test to screen in this population. Next. So treatment of diabetes in this age group, this is an important point. In elderly patients, they can tolerate hyperglycemia actually to a better extent than the normal individuals, because they will not develop polyuria. So the symptoms wise, their presentation will be slightly different, and this is because their kidneys, their GFRs are low to begin with, so they will not develop as much polyuria as some of the younger type 1 diabetics in whom the polyuria is the major complaint. And that therefore it is not surprising that these individuals, these elderly patients will come when they are diagnosed, they have very high blood sugar, 600, and it's not uncommon for them to present with the hyperglycemic hyperosmolar syndrome, because they can tolerate hyperglycemia slightly better than the younger individuals. Next slide. Okay, so before we start treating these individuals, there are two things we need to keep in consideration. Number one is their overall health status, how healthy they are, and what sort of personal values and goals we need to set up for these individuals. Because if they are frail and elderly and have poor lifespan, short lifespan, depending on their comorbidities, then we really don't need to be too aggressive. So that's the first thing. And the Endocrine Society recommends that in these individuals, we should do cognitive testing every 1 to 2 years when they come to see us in the clinic. And the reason is that if they have some cognitive deficits or it's worsening, then no matter what treatment plan we make for them, it's bound to fail. And we should tailor our plans and make it as easy and less complex as possible if we feel that these patients have cognitive deficits. Next slide. This is a busy slide, but I think the important thing is this is highlighting the same thing that we talked about in the last slide. So when we see these individuals, so newly diagnosed type 2 diabetics who we are seeing in the clinic for the first time, the first thing is we should see how healthy they are. So if you see here the group 1, which is good health, so they have no major comorbidities. They have some diseases like hypertension, osteoarthritis, so non-diabetes related illnesses, but they are totally independent of activities of daily living and also the instrumental activities of daily living. So they are completely independent, like all of us in the room and you people. So the only thing is that they are more than 65. They have some comorbidities, some diseases like hypertension and arthritis, but nothing that is affecting the quality of life. So in these individuals, we should set a target of fasting blood sugar of between 90 to 130 and bedtime numbers between 90 to 150. With a target A1C in this age, in these kind of people, patients between less than 7.5. And if we cannot achieve these targets of fasting and bedtime, then we should consider adding medications that have hypoglycemia as a side effect. So if their fasting blood sugar is consistently running more than 150 and the bedtime numbers are more than 180, then we should consider adding insulin, which can increase the risk of hypoglycemia. This is in contrast to the second group, where these individuals have, they are sicker than the first group. So they have 3 or more non-diabetes related medical illnesses. So they have hypertension, they have had minor TIAs and stroke, they have CKD stage 1 to 3, plus they have early mild cognitive impairment, and which is also limiting their cognition. So in this group, we should set a target of, our A1C target is around 8, and the fasting targets are slightly higher than the first group, and the bedtime targets are also higher. So that's what we are shooting for. And if we cannot achieve that by giving medications, which we will talk in the next slide, safer diabetes medications, that's when we should consider adding insulin and other medications which can increase the risk of hypoglycemia. The third group, these are the sickest patients. So they have end-stage medical conditions. So they have either a malignancy or they are on dialysis. They have significant COPD and they are oxygen dependent. So in these individuals, and they are also limited in how much they can do. In these individuals, our target is around 8.5. with a higher fasting target and a higher bedtime number target. And if their numbers are higher than 180, fasting consistently, and bedtime numbers are greater than 250, that's when we should add medications that can increase the risk of hypoglycemia, such as insulin. Yeah. So next slide. Any questions about this? Because I think this is, most of us, take this into consideration, but this is for the first time, Endocrine Society has written it out like that and divided patients into different groups based on their health status.
I have a quick question. This is Jennifer. Wait a minute.
I have a quick question.
This is Jennifer Boyd. You might have said this, but I was offline for a minute. Is this type 1 or type 2 diabetes, or just type 2?
Type 2. Type 2. But again, the targets are, even if this is the type 1, we should keep the same targets in mind depending on their health status.
Okay, thank you.
But these guidelines are predominantly for type 2. Okay, so the medications, the safe medications for this age group are the ones that will not cause hypoglycemia by itself. So we know, the Metformin by itself will not cause hypoglycemia. The Januvia and the Onglyza and Tradjenta, which are DPP-4 inhibitors, they will not cause hypoglycemia by itself. The GLPs, which are the injectable daily or weekly injectable medications, they will not do this hypoglycemia as well. Jardiance, Invokana, and Farxiga, they will not cause hypoglycemia. These are the SGLT2, and Actos won't. But again, there are two classes which are prone to cause heart failure, especially the Actos and the DPP-4. So if we can avoid these medications, especially in patients who have a history of heart failure, we should avoid in that situation. Next. So, a newly diagnosed type 2 diabetic patient more than 65 years of age, the first line of treatment is Metformin. In addition to the lifestyle, the resistive training, increased physical activity and diet that we talked about before, is still Metformin. The only time we should not start Metformin is if their GFR is less than 30. So if the patient's GFR is less than 30, then that is a contraindication. If the GFR is between 30 to 45, then we should use between 500 to 1,000, but should not go more than that. And always start slow and increase the dose with a period of time to see if they can tolerate it. So that's the only contraindication to Metformin. Age used to be a relative contraindication, but essentially, it is not a contraindication anymore. So once we start the Metformin and patients are tolerating the Metformin with the diet, and in spite of that, we are unable to achieve our targets, the targets that we talked about, depending on their health status, and then the numbers are still high, then we should add other medications. And again, we should keep in mind that we should avoid agents that can increase the risk of hypoglycemia. So weekly in GLP, I think is a very good option. Just one injection a week. And less complex regimen. So that is something that I will add to these patients. And these medications, the weekly GLPs, they can be used even if their GFR is slightly on the lower side. So, and again, with Metformin and by itself, it will not cause hypoglycemia. I think the medications that we should avoid are the sulfonylureas, especially the glyburide. It has a long half-life and then can cause significant low blood sugars. And medications such as Starlex and Prendin, these are the netiglinide and the rapaglinide. We should avoid that as well because it's, number one, they are expensive. Number two, they can cause hypoglycemia as well. Next. So these are some of these supplemental resources that we should consider for this age group, these patients. Number one, large print, audio, and visual educational material so they can read, because most of them have vision problems. Glucose meters with the background light or the talking meter so that they can write down their blood sugars and they know how high their blood sugars are. Glucose meters with drums, so that most of them have problems with dexterity. So to fix this, a small test strip into the meter, it will be too taxing for them. So meters with the drum may benefit them. Similarly, lensing devices with the drum, which contain multiple lancets, that will help patients who have dexterity issues. And of course, continuous glucose monitoring system, the 14-day or the 10-day Libre sensor will be very helpful. Syringe magnifier, especially patients who are using insulin and with the needles, that will be very helpful for them as well. And I think I have some pictures on the next slide, so if you can turn on the next slide. So the first one, it is the test strips with the drum. Again, each drum can contain up to 25 lancets. So they don't have to change the lancets and the test strips on a frequent basis. So that will be helpful for them. The second one, the insulin syringe with a magnifying glass, that can help them see exactly how much they are injecting. If they cannot see properly, then they are more likely to either inject too much or too little, leading to problems. And then meter that can talk back, so that they know how what the blood sugars were when they tested. Next. This is the last slide, and this is just what is the blood pressure target in older individuals with diabetes. So the targets are in patients more than 65 and between the ages of 65 and 85. So for primary prevention, meaning that they have not had any problems with strokes or coronary artery disease, or they don't have CKD, then their targets are 140 systolic and 90 diastolic. So slightly, higher targets. But if they have problems and you're controlling blood pressure for secondary prevention to prevent further strokes and progression of CKD, then we can actually select a lower target with medications, which will be systolic of 130 and diastolic of 80. So again, we don't have to be very aggressive in this age group. That's the bottom line of the recent guidelines. So that's all I have in terms of diagnostics.
All right, guys, are there any questions about this? I know that we have a lot of people from MVA on the line, so feel free to unmute yourself.
I have a question. I know for patients in nursing home, as per that best practice, they say don't check blood sugars frequently, especially when they are in insulin. So what's the best strategy for nursing home patient?
Okay, so that depends on what they are on. If they are just taking Metformin, for example, or a DPP-4, which we know will not cause hypoglycemia. So these individuals, I think twice a week is okay, different times. But if they are on insulin, if they are on complex regimen, if this is a type 1 diabetic who's taking 4 injections a day, then I think we need to check at least 2 or 3 times a day, because hypoglycemia will hurt them more. It can cause seizures and ventricular fibrillation, and they can actually die from it. So it all depends on what their regimen is. If they are on complex regimen with multiple insulin injections, then checking it is the right thing to do. Otherwise, I think even the American Geriatric Society recommends just checking it twice a week in patients who are on oral hypoglycemic agents.
And another question is, it's both in nursing home and in outpatient setting, where we come across patients who are very concerned about their blood sugars at bedtime. Okay, like I know we have them check their blood sugar at bedtime also, and when it's high, they try to give themselves extra insulin. Me personally, I'm concerned about that with low blood sugar in the morning, but because it is ingrained to them that anything more than 200 is bad, so they tend to give themselves extra insulin. So what's the best practice?
Yeah, so I agree with you. I think if they are taking especially a bolus insulin, like a Novolog or Humalog at bedtime, and it peaks in about 2 to 3 hours and lasts for 4 to 6 hours, they are at risk for that is a major risk for hypoglycemia. Even in the slides where we were talking about, the target is about anywhere from 150 to 180, and that depends on their functional status as well. So I want my patients, elderly patients, to go to bed with numbers closer to 180, especially if they are on insulin. I don't want the numbers to be dropping. So I think that will need some education on part of the providers for the patients to for them to understand that low sugars, again, this is what I tell my patients, low sugars are much more dangerous than high sugars in the short term. You can actually die from low sugars, especially if this happens in the middle of the night. So I want the numbers depending on how sick they are, between 150 to 180 if they are frail elderly patients.
Thanks.
You're welcome.
All right, guys, we're going to move on to the cases, but if you guys have any questions at the end, please just let us know. All right, Jen, are you good if I share the screen?
Yes, I am. And just so everybody there knows, I'm at home actually with a little bit of a flu, but I'm in recovery, but my internet is now on the blink, so but I have phone, so if I disappear from the screen, I hope I'll be able to just stay on by phone. And you're pulling those cases up, right, Caitlin?
Mm-hmm.
Is it up or not yet?
It is up. Can you guys see it or not?
It's weird. I can't see it.
Okay, give me 1 second. Let's see.
Is it my 52-year-old or my 58-year-old?
Let me see. Your first one is a 52-year-old.
Okay.
Can everybody else see it? Yeah. Okay.
So it's just me?
I'm sorry.
That's okay. It's not my day. Let's see if I don't know why I can't see it. But so I don't know what Caitlin is showing there, but let me just talk about this 52-year-old